Good afternoon. Thank you for the invitation, and thank you all for coming. I have no financial disclosures. That was on my first slide. I was one of the writers for the appropriateness criteria, but I did not get any financial remuneration for that. So we will briefly talk about calcium scoring, CT angiography. What are the different patient-based clinical scenarios that you in the primary care community could be dealing with? I think it's also important to know what some of the limitations are, as well as some of the radiation-related issues. So let's just get started. CT is very new as a technology for assessment of cardiac or coronary structures especially. Most of us, at least I certainly know what I was doing in 2003, 2004, which is when the real cardiac or coronary allowable CT angio, the 64 slice, came into full swing. That was in 2003, 2004. And within a span of a decade, this technology has evolved tremendously, and we can do now a lot of things with a lot of new data emerging, which is both exciting as well as intriguing and calls for future work. So what are some of the technical advances in terms of CT? So when it was 4 slice, basically you would have a 30 or a 40-second breath hold. That's torture. That's Guantanamo Bay, if you want to know. From there, it has gone down to 5 or 2 seconds worth of breath hold time. You can basically get pretty much the whole heart covered in a span of 1 cardiac cycle, and your 0.4 millimeter slice thickness, which allows for sub-millimeter imaging and looking at coronary structures. And now, it is, I make no mistake, it is not live imaging, okay? It does not allow live imaging like cath or echocardiography, but it can still also do cine images with some of the advanced scanners. What are some of the different patient-related scenarios? So let's take an asymptomatic person without known CAD, the worried well, the executive health, the whoever. I just want to know what's going on in my life. So in an asymptomatic individual, clearly we have to be proactive rather than reactive in terms of your approach. Why is that? About 60% of men and 40% of females, their initial presentation of CHD is an MI or a sudden cardiac death event. That's not good statistics. You can perhaps open up a coronary artery after an infarct, but if you present with sudden cardiac death, the survival rates are pretty dismal. How good is your NCEP, ATP III, framing M, et cetera, at predicting MI? This is a study done about 10 years ago, 222 patients with first acute MI, no prior coronary artery disease. These are young men, relatively young female, non-diabetics. The day before their acute MI, 71% would have qualified in the low risk category. 75% would not have qualified for lipid-lowering pharmacotherapy. So on day after MI, we will put them on 80 milligrams of atorvastatin. Day before MI, you would say you don't need this. So there's a disconnect here. This holds more true in females where till you are 70 or 75, you don't even make it to the intermediate framing M risk score. And so females are grossly underrepresented when it comes to your risk factor prediction. So what we do need is something beyond standard risk factor prediction. One of the things that can be done is coronary calcification, where you do a non-contrast CT of the heart, where you look for specks of calcification for which we define what is calcification and what is noise. And basically, you say whether there is calcification, and you grade it based on the Hounsfield unit criteria from mild, moderate, severe. And this works pretty good. These are 3 examples of somebody with intermediate likelihood of disease. The first picture, there is no calcium. Middle, there's mild calcium. And then the bottom one has severe calcification. Now, it's not one size fits all, obviously. the calcification pattern, even in a normal individual, this was studied in the MESA study, which is an NIH-sponsored study. They showed that it is a factor of age, it is a factor of gender, as well as ethnicity. So you cannot use the calcium score in a 65, from a 65-year-old predominantly Caucasian male population and apply it to a Chinese cohort or vice versa. So because the appearance of calcification is very, very different amongst these groups. Now, any test, any imaging test, you have to test it in terms of its incremental prognostic utility. One of the first studies that looked at calcium scoring, this was published out of Northwestern now 10 years ago, where they showed that there was incremental prognostic utility of the pink ROC curve is Framingham risk score plus calcium scoring compared to Framingham risk score, and this was over a mean follow-up of 7 years. So there was significant improvement in prediction of future events. A larger, much larger observational study, 25,000 patients, again showed that if your calcium score is 0, your long-term outcomes are good, up to 12 years of follow-up. Compare that to your calcium score is greater than 1,000, you got problems. And there is a very nice gradation in between. Similarly, the MESA study followed up and showed very similar results. If you have no calcium, your outcomes are good. If you have severe calcification, your outcomes are significantly worse. And this was in 6,700 patients. This is an interesting study published a couple of years ago now in Lancet. They took the MESA population, and in that they found a group where the LDL was low, but your CRP was high. This is sort of the Jupiter trial. So inflammation, people had inflammation yet low LDL levels. Otherwise you would not treat them, but Paul Ritker would say, go ahead and start everybody on statins. This study, what they showed was if your calcium score was 0, your outcomes are good. Your calcium score was greater than 100, your outcomes are worse. So even if you have high CRP, doesn't automatically mean that everybody should be started on statins. At least according to this study, you can still further risk stratify these patients. Now, this is published in JAMA last year, where they looked at, again, the MESA population and utilized Framingham risk score plus C-reactive protein or carotid IMT or ankle brachial index or flow-mediated dilation of the brachial artery. And what they showed was combination of Framingham plus calcium scoring was the best in terms of predictor for future events. So this is basically in terms of strength in the C statistics, the C index, the ability to discriminate and predict future events, calcium scoring is coming out good. And these are not observational studies. These are NIH-sponsored prospective studies. Now, changing gears a little bit, is there a role for CT coronary angio? And we will talk about other indications in detail. For an asymptomatic individual who is coming in worried well for screening purposes, according to this study published now a year ago, there is no incremental benefit for coronary CT angio, at least in an asymptomatic person without known prior CAD. Okay? Now, so what do the appropriateness criteria guidelines say? Hopefully it is projecting well. What they say, pink is bad and green is good, basically, okay? What it says is the right side here is coronary CT angiography. Basically, it's all inappropriate. On the left side is talking about calcium scoring. If you never had a calcium score in the past and you have a low Framingham score with a positive history or an intermediate score with or without family history, these are appropriate indications. If you have just pure low Framingham risk score, you're a 23-year-old with atypical whatever, not a good idea. If you have a high Framingham risk score, you should basically treat them, not worry about their calcium score or what have you. At least that's according to the guidelines. What about symptomatic person? You have somebody presenting to your outpatient scenario. The broad theme is it is good in symptomatic individuals who have intermediate pretest likelihood. So here, this is not Framingham risk score. This is the Morrissey criteria. This is the Diamond-Forrester criteria, et cetera. So if you have intermediate pretest likelihood, CT angio could be good. Now, what are some of the strengths of coronary CT angiography? The strengths, and I think for any imaging test, you have to know what the strengths are. And more importantly, you have to know what the weaknesses are. The strengths are very high sensitivity and very high negative predictive value, meaning if you have disease, we are going to see it. If you don't have disease, we can very confidently exclude it. The issues are quantifying the precise degree of stenosis, and I will talk a little bit about that in a second. Now, stenosis grading is not exact science. Even in cath, most of people eyeball the numbers. So it is 40 to 60, 50 to 60. You want to do a PCI, then it becomes 70%. You want to avoid a PCI, then it goes down to 45%. So a lot of, you can do QCA, but a lot of it is eyeballing. And it's the same situation with CT, but where you can use 3D post-processing to precisely measure. But sometimes with artifacts and calcium blooming, et cetera, it can become difficult in precisely quantifying. Now, I want to show you this case. This was one of the early cases I dealt with. 52-year-old male who presented with atypical left shoulder pain. Basically, look at the CT angio. It shows a very tight mid-LAD lesion, zero calcium. Zero calcium. This is a very tight, non-calcified plaque in this guy. He subsequently went on to have angioplasty, and he's doing well. But this is the strength of CT angio. It not only looks at the lumen, but it can look at the vessel wall, and also whether or not there is calcification or not, obviously. Now, this is something recently published. Where does CT angio fit in terms of symptomatic individuals? So let's focus on the right-hand side first. If you have typical angina, the expected prevalence based on Diamond, Forrester, or Morrissey criteria, the expected prevalence is far worse than what you actually observe in terms of actual CAD. In asymptomatic individuals, the observed prevalence is a lot more than what is expected. So both sides of the aisle, basically, CT angio can better characterize or better risk stratify these patients more than above and beyond what Diamond, Forrester, or Morrissey criteria can do. Now, again, prognosis. For an imaging test, it is important to have prognostic data. According to this confirmed registry, if you have no CAD, your outcomes, intermediate term outcomes are very good. If you have 3-vessel CAD, your outcomes are pretty darn, are significantly worse compared to rest of the group. The confirmed score, and based on this, in a 17,000 patients and a validation sample of 2,500 patients, what they have shown is the confirmed score that is based on where the disease is and how severe the disease is. So left main gets higher score than LAD, gets higher score than RCA, distal RCA. So using that confirmed score, which is now easily available for patients, it provides incremental value above and beyond the Morrissey score, ATP, or Framingham risk score, both in a test sample as well as in the validation sample. Now, so where does CT angio fit in the setting of prior test results? If you had a stress test with discordant results, so abnormal, highly abnormal ECG, but normal looking stress echo or nuclear, or an unclear nuclear, for the lack of a better term, it is appropriate to break the tie. If your test shows severe ischemia, then you don't need to stop for a drive-by CT, just go straight to the cath lab. On the flip side, if you have somebody who's coming to your OPD year after year, asymptomatic, no major change in his clinical situation, it is inappropriate to just, oh, by the way, I want to check how your CT angio looks or your stress test looks. So these are inappropriate indications. If you have somebody with worsening symptoms and they've had a past study, if the past study was negative, then there's a change in clinical situation. It's appropriate to consider CT angio in this particular situation. If it's abnormal and you chose last time to do nothing, then there's basically no real need to look at it. What happens? Calcium leads to, when photons fall on the calcific lesion, it tends to bloom, and that tends to overestimate the degree of stenosis. In that situation, your positive predictive value drops, and you can be wrong a lot of times. So if your score is greater than 400, you should probably avoid CT angio. So in other words, you have a 75-year-old obese guy who smokes, diabetic, hyperlipidemic, et cetera, then you are better off with a stress test or taking them to the cath lab as opposed to sending them for a CT angio. In other clinical scenarios, when you have new onset congestive heart failure, so if your patient presents to you with EF of 30%, which is new onset, the class 1 indication is considered doing some sort of angiographic evaluation. If that patient happens to have a high pretest likelihood, then you're better off sending that person to the cath lab. But if their pretest likelihood is low to intermediate, then this can be used as a viable alternative. CT angio can be used as a viable alternative. Now, prior to non-coronary cardiac surgery, so valve surgery, myectomy, other cardiovascular surgeries, if your pretest likelihood is low or intermediate, then it is good to consider. It is a good option to consider basically a CT angio. If it is high pretest likelihood, then just send them straight to the cath lab. AFib, basically, I would not recommend CT angio. At least the guidelines don't recommend CT angio. And just evaluation of syncope, CT angio should not be the first line. There should be other things you do. Non-cardiac surgery, I'm sure you guys deal with this a lot. Impact center, people who work in the impact center, according to this, basically there are no definite guidelines, or there are no indications where CT angio is considered appropriate. This is more than likely to change in the future with more availability of data, but essentially a lot of stress testing we do is inappropriate in those patients. CT angio for sure is also considered inappropriate. Now, a good emerging indication is that of evaluation of patients who present with acute pain in the emergency room. That's a big business, $10 billion business, 8 million patients in USA. Again, these are previous non-randomized studies. The key is to recognize the strengths of these technologies. High negative predictive value, meaning, and high sensitivity. If you have disease, we are going to find it. And if you don't have disease, you can safely send the person home without having to worry about him or her dropping over dead. This is a very nice example of a patient that we had seen, a 48-year-old female just going from hospital, Metro to UH to Cleveland Clinic to Hillcrest to wherever with chest pain. And she would get a stress test, nuclear test, stress test, nuclear scan, what have you, and continues to complain of pain. Comes into Cleveland Clinic, we do this acute chest pain protocol. Her coronaries are totally clean, and she basically, we told her she has no CAD, we should look at other causes, perhaps see a rheumatologist for fibromyalgia or what have you. And we were able to do this at very low radiation dose. Now, what is the data? There is 3 major randomized controlled trials that have been published in the last 2-3 years. The ACIRN trial, the CT stat, and the ROMICAT study. What they have shown is, compared to your standard strategy, CT angio, you can send the patients home quicker, it is less expensive, and it has a higher rate of detection of CAD. More importantly, it is not hurting the patients. By sending these patients earlier home, you are the same number of people have, or a very low number of people have adverse events compared to nuclear or what have you. This is the CT stat study done out of Michigan. Again, same findings at a much lower cost. This is the ROMICAT study performed at Mass General in Boston, where they showed very similar results, except in this case, there was a slightly higher risk of downstream revascularization. But that is something that can be monitored and adjusted. So what are the guidelines? What do the guidelines say? If you have ST elevation ongoing, then please don't stop for a drive-by CT. You need to go straight to the cath lab. If you have normal ECG and cardiac biomarkers, but if you have low or intermediate TIMI risk score, then it is appropriate to consider CT angio. In high pretest, as of right now, it is considered an uncertain indication, but that could change. So you have to use your judgment in that situation. Most of us would agree that they should go to the cath lab. So how do I use in terms of triage of patients based on CT angio? You have the CT angio, now what? You are the emergency room doctor. If you are 0% coronary stenosis rate, then you can safely discharge from the ED. If you have mild disease, discharge from the ED and make full utilization of the same day access at the Cleveland Clinic Department of Cardiology. There will be somebody who will see them same day. If you have moderate disease, then you can send this person for stress or cath lab with fractional flow reserve. And if you have severe, obviously they need cath plus minus PCI. So this is a thing that I use in my mind when I'm making a recommendation, or if I were on the other end as an emergency room doctor, I would potentially use this. In terms of post-revascularization, what is the role? So this, most of the PCPs, I mean, they would defer this to the cardiologist, but I'm still gonna mention it. Stent assessment by CT is problematic, especially if the stents are less than 3 millimeters in size. It is good to exclude in-stent restenosis. It is good to detect in-stent restenosis, but it is not very good to quantify the degree. And that's why the guidelines suggest that it is, if the stent size is less than 3 millimeters, then CT should be avoided. Bypass graft, on the other hand, it is pretty good. High sensitivity, high negative predictive value, much higher specificity and positive predictive value because they are bigger and they don't move as much as coronary arteries. This is a study that was published a couple of years ago, which again proved incremental utility, prognostic utility of CT angio. So if you have one vessel disease and a protected territory, that's the line 1, that has the best outcomes. If you have 3 vessel disease and every territory is unprotected, your outcomes were worse. And this was evaluated on CT angio. So again, additional prognostic data in close to 700 patients. So what are the recommendations post-revascularization? Let's look at the right side first. This is dealing with stents. The only one indication that was deemed appropriate in terms of CT and stents was if you have a left main stent that is greater than 3 millimeters in size, it is okay to periodically check them because if the left main stent goes down, the person checks out of this planet. So this is a good indication. Other than that, everything is pretty much inappropriate indication. On the flip side, what happens if you're symptomatic and you have bypass grafts? If you have symptoms and you had prior history of coronary artery bypass grafting, it is appropriate to consider CT angio in lieu of cath, especially if the pain is sort of squirrely, it is not your real anginal sounding pain, et cetera. Basically, other than that, in terms of revascularization, in fact, from a primary care perspective, I would urge to defer it back to the cardiologist to make the decision which is the right channel, stress test, direct cath, or a CT angio. In terms of coronary anomalies, suspected coronary anomalies, CT, and in younger patients, coronary MR angiography, these are the gold standards. Not cath, certainly not echo. This is tomographic modality is the gold standard. Not only identifies the anomaly, it looks at the course of the vessel, it also looks at the association with other structures, and more importantly, it looks for other congenital anomalies that the person could potentially have. Now, as I told you earlier, CT is not just about stenosis, there's also, it has the ability to look at plaque. This is a population of people with suspected ACS, acute coronary syndrome. What they showed was if you have an outwardly remodeling plaque as well as low attenuation, so non-calcified plaque, basically if you had both these features, your outcomes were worse than having no features. On the flip side, just standard symptomatic patients who underwent CT angio. So in people who did not have significant stenosis, if you had any non-obstructive plaque, if you had no non-obstructive plaque, your outcomes were good. If you had plaque, these are non-obstructive plaques. In 1, 2, or 3 vessel disease, your outcomes were proportionately worse. And this is hard event data. So what are the pitfalls? Nothing comes free for a lot. I mean, it's sort of, coronary is sort of like getting married. You get the good-looking wife, but you also have to deal with the outlaws. So the artifacts are the in-laws here. So you have to deal with the calcification, which results in reduction in accuracy of stenosis quantification. You could have artifacts. You could have obese patients, the McDonald's generation, where the photons don't penetrate and the diagnostic quality is suboptimal, or you could have all these hardware, which makes it difficult. It is important to recognize these. My advice to fellows and referring physicians is patient selection is key. If you're going to select an 80-year-old guy, you're going to have problems. 80-year-old guy with pacemaker and cannot hold his breath and this and that. This is going to be a problem. So appropriate patient selection is key. And when in doubt, call, and we would guide you through this. What are some of the emerging concepts? So things that are being worked upon is this comprehensive protocol where you can do a stress test, a rest scan, and a viability delayed scan in a span of 20 minutes, and you can have information on viability, coronaries, as well as ischemia. And this can be done at lesser radiation than a single nuclear scan. What else is emerging? From your standard REST CT angio, you can non-invasively calculate fractional flow reserve. So if you add this to the previous protocol, basically you don't even need to do an adenosine fractional flow reserve in the laboratory if the numbers hold true. So these are some of the things that are being worked upon and emerging as we speak. So in the next few years, things are going to rapidly evolve. You obviously cannot and should not talk about CT or nuclear without talking about radiation. The bottom line is no radiation is safe, and something is worse than nothing, and it should be kept as low as reasonably acceptable. So from a CT perspective, where does this hoopla come from? This is from a study published out of New York by Andrew Einstein's group. He took the Hiroshima data and then modeled and created a hypothetical model using one coronary CT angio. So if you have a young female who is 30 and who gets 20 millisieverts, a full blast of radiation, her likelihood of developing cancer, these are hypothetical models, was about 1 in 143. Compare that to an old grandpa who gets radiation reduction, 9 millisieverts at 80 years of age. Something else is going to kill him before radiation does. So it is important to recognize this and basically take precaution. Again, prevention is the best. You have to stop and ask, do you really need this test? Now, radiation dose, you cannot talk about an isolated test. Bottom line is CT, it started off with 15 to 20 millisieverts. We can do a CT angio now in as low as 1 millisieverts in selected individuals. Compare this to nuclear, where we still give a sizable dose of radiation for a given patient. And this has not changed for a long time. In fact, this is a good segue to Dr. Jaber's talk. In cardiology, the biggest source of radiation is nuclear procedures. This is data published in 2010. This is not our data. This is what has been published in JAC. Basically, overall, 70% of all radiations that patients get comes from nuclear procedure. Now, from a CT, what can we do? What do we do? Basically, we need to know what the patient is, and we tailor the protocol according to a given patient. It's not, one size fits all. We can reduce the voltage with 53% reduction in radiation. We can reduce the current and reduce it by 20%. 1 centimeter reduction in the z-axis from top to bottom can reduce the radiation by 5%. We can use newer scan modes that can go down to 1 millisievert. Most of the times, with the right selection of patients and parameters and experienced personnel, image quality does not suffer. And I would leave it to the people who are doing it to decide what technique to use. Now, it's not all hunky-dory. This is a study that got a lot of press, published in JAMA. This took everybody that had a coronary CT angio across the world in academic as well as private settings. So for the same indication, there was a huge variation in the amount of dose given to a given patient. So you come to main campus Cleveland Clinic, your radiation dose is 2 millisieverts. You go to Ashtabula, it may end up being 25 millisieverts. So this is just an example. And on multivariate analysis, The reason that was given for this was, one of the primary reasons was experience in cardiac scanning was inversely related to the radiation dose given. So this is important to know where your patient is having the scan. So I think I will conclude by saying coronary calcium and CT angiography is mature enough to be mainstream. Again, you have to know what the strengths are. Negative scan is very good for prognosis, both in symptomatic as well as asymptomatic people in terms of CT angio and calcium scoring respectively. There is, especially in the ED population, a large-scale registry and randomized control trial data is available, and the recommendations are going to evolve over time. You have to know what to use, when to use, how to use, and more importantly, I think it is important to know when not to use. Emphasis should always be on radiation reduction. So thank you so much.